All right, welcome everyone. Let's dive right into this concise explainer on the critical updates from the 2025 Hungarian guidelines for managing triple-negative breast cancer. We're going to focus on the major shifts that are absolutely going to impact your day-to-day clinical decisions. So here's our game plan. We'll start with the big picture, the new way of thinking about TNBC. Then, we'll walk through the new strategies for early-stage and metastatic disease. And finally, we'll wrap it all up with the key takeaways you can put into practice immediately. First up, let's talk about the fundamental change in how these guidelines frame TNBC. The headline here is a major shift towards precision medicine. So this is the core idea, the big paradigm shift. We are officially done with the one-size-fits-all approach. The days of treating TNBC as this single, uniform disease with just blunt chemotherapy, well, those days are over. We're now in the era of a much smarter, biomarker-driven strategy. And speaking of nuance, this is a huge update. The guidelines now officially pull these ER-low positive tumors under the TNBC umbrella. The evidence is clear. Biologically, they act more like TNBC than luminal cancers. So from now on, we manage them according to TNBC principles. This is a really key reclassification. And this number right here really shows you the why behind this thinking. About 80% of what we call TNBC is genetically basal-like. This just hammers home the point that we need treatments that target the underlying biology, not just the surface-level receptor status. Okay, let's move on to early-stage disease, because here, the new guidelines don't just suggest a path, they lay out a new, mandatory standard of care. The entire treatment journey for high-risk early TNBC is now incredibly standardized. It's a clear four-step process. You start with neoadjuvant chemo plus pembrolizumab, then surgery. After that comes the crucial assessment for PCR, because that result is what's going to dictate your next move in the adjuvant setting. And this is, without a doubt, one of the most practice-changing updates. Thanks to the compelling data from Keynote 522, adding pembrolizumab isn't just a good idea, it's not just an option, it is mandatory. It's the new, non-negotiable standard of care to improve event-free survival. But, of course, what happens when you don't achieve that pathological complete response? For patients with residual disease after surgery, the risk of recurrence is obviously higher, and the guidelines now give us a very clear stratified path forward. Now, this is where things get really elegant. The adjuvant therapy path literally splits in two. Your decision is now driven by one key piece of information, the patient's germline BRCA status. If they're wild type, it's Capecitabine. But if they're gBRCA positive, the standard is now 1 year of Olaparib, and that's based on the powerful overall survival benefit we saw in the Olympia trial. Okay, let's tackle the metastatic setting, and here, the algorithm gets even sharper, creating a very clear decision tree that's dictated by specific biomarkers. In the first-line metastatic setting, this is it. This is the first and most important question you have to answer. Is the PD-L1 CPS score greater than or equal to 10? This is the gatekeeper for immunotherapy. And if the answer is yes, if that CPS is 10 or higher, the guideline is crystal clear. The standard of care is pembrolizumab plus chemotherapy. There's a proven overall survival benefit, so this should be your automatic go-to regimen. So what if the tumor is PD-L1 negative? Well, the algorithm doesn't just stop and default to standard chemo. We now have another critical branch in the decision tree, and it all hinges on the patient's germline BRCA status. This table just lays it all out perfectly. It's a clean, tiered approach. First, you test for PD-L1. If it's negative, you test for gBRCA. Only if both of those are negative do you proceed to single-agent chemotherapy. It's a beautiful biomarker-led cascade. Now let's look beyond the first line, because this is where the treatment landscape is being completely reshaped by a truly powerful class of drugs, the antibody-drug conjugates, or ADCs. So, the single most important thing to understand here is that ADCs are no longer a salvage therapy that you save for the very end. No way. They are now the established standard in the second-line setting and beyond, and this really changes how we think about sequencing. Sacituzumab Govitecan is now firmly cemented as the preferred choice here, with the level 1 evidence we got from the ASCENT trial, which showed it was superior to standard chemo. It's become the benchmark that we measure everything else against in the second line. And then there's this.
another absolute game changer. T-DXd basically carves out a brand new treatable population from what we used to just call triple negative. Thanks to DESTINY-Breast04, identifying HER2 low status is now essential practice because it unlocks an incredibly effective therapy for these patients.
Okay, that was a lot of information. Let's boil it all down to the most critical, practice-changing points that you can take back to the clinic tomorrow. Look, if you remember nothing else, remember these 4 things. 1. Treat ER-low positive as TNBC. 2. Neoadjuvant Pembrolizumab for high-risk disease is mandatory. 3. Adjuvant Olaparib is the standard for gBRCA positive patients with residual disease. And 4. ADCs are now the standard of care in later lines. These are the 4 pillars of the new guideline. So this leaves us with a final thought. This rapid evolution from just blunt chemotherapy to precise, biomarker-driven medicine, it's not some far-off future. It's here, right now. The real question for all of us is, how will we integrate all this complex testing and sequencing into our daily practice to really move the needle on patient outcomes?